So I think if you take a look at how diagnostics were thought of in the past, it was a question of is this diagnostic valuable? And the question was, it's valuable if it can drive a clinical decision, right? So which drug do I use? Which surgery do I do? Whatever the clinical intervention was, it was, do I do this or not? And if it can't answer that, this is a useless test. Don't cover it. Don't pay for it. I mean, that's what it sort of used to look like. But today, I think it's a little bit different because yes, it has to have an impact on your clinical decision making, but your clinical decision is so much more complex than, do I give this drug? Do I do X versus Y? It's, which of these drugs do I use? Do I use a different dose? Do I use different drug combinations? Does patient X need a different approach than patient Y? Even in GLP-1s, for example, with this multitude of pipeline coming down that Eli Lilly has, you're going to have multiple products coexisting, and potentially, one product will work for one patient better than another or cause less side effects better than another, similar to what we've been seeing in the evolution in the oncology space. So if this is not just an oncology question anymore, but every indication is now going to require biomarkers to guide, which is the optimal approach for treating patients, whether it's branded medicines or biosimilars or good old generics. That is a tool then that helps you to manage the costs in your population, right? So rather than guessing, you now actually choose the appropriate thing, no matter where on the cost spectrum it lies, because you hopefully it leads to better outcomes. So if it can deliver on that promise, then I think diagnostics are really the tool that payers can use to figure out how to optimize the outcomes for the best cost.